Hello, dear friends. It's so amazing to meet all of you during our traditional webinar to discuss the main important questions of multiple sclerosis treatment, the main important questions of our activity. So we are ready to answer all your questions, but our plans for today is to present our new data, to inform us about our activity, and to answer all your questions. So I am really happy to meet all our friends from all countries around the world. So, hello.
Hello, Dr. Fedorenko. Hello, everyone. I am also very glad to welcome all of you to our webinar.
Okay, so dear friends, let's start with short presentation, approximately 5-7 minutes, about our activity, our result in this year, and then we will be ready to discuss all your questions. Let's start with short presentation. So our traditional presentation is high-dose immunosuppressive therapy with autologous hematopoietic stem cell transplantation in multiple sclerosis. This is the main activity of our hospital. As you know, we are Department of Hematology and Cellular Therapy. It's important to know that this is governmental university hospital, clinical and research. Together with routine clinical practice, we provide lots of clinical research to improve treatment, to analyze treatment results, to develop new approaches. As you know, our department was created in 2003 and transplantation department was created in 2005. And this year, our department was named after Maximov. This is famous Russian histologist who developed stem cell theory. The first transplantation and multiple sclerosis in Moscow we provided in 2005, but in Russia, in St. Petersburg, earlier in 1999. For today, we have provided more than 4,000 transplantation for hematological malignancies and autoimmune diseases. So I think this is one of the biggest single center experience. On this slide, you can see that totally we have provided almost 2,000 transplantation for different autoimmune disorders from 2005 to 2022, and mainly for multiple sclerosis. Today in our database we have result of 1,903 patients. Additionally, we provide transplantation for other autoimmune diseases. This is chronic inflammatory demyelinating polyneuropathy, neuromyelitis optica spectrum disorders, very rare condition like stiff person syndrome, some rheumatic diseases, ankylosing spondylitis, systemic lupus erythematosus, arthritis, systemic sclerosis, myasthenia, and some autoimmune disease of bowel. In this year, we published very big article in Acta Scientific Neurology journal, and we published a result of big group of patients. Later, I will show you our results of this group. Also, during European conference, we published information about our new protocol. So now this protocol is really official, and we have information about toxicity, about previous result, about positive and negative side of this treatment. On this picture, you can see relapse-free survival time in relapsing remitting patients after transplantation. 258 patients were analyzed, and it's important to notice that after transplantation, the vast majority of patients with relapsing remitting multiple sclerosis were relapsed-free. You can see 245 patients out of 258 patients. So mean time until relapse was more than 2 years. an estimated relapse-free survival at the follow-up of 3 years was 95%. So the result of transplantation for relapsing remitting group of patients is more than 90%. For the follow-up of 5 years, this result is also almost 90%, and the longest follow-up, 84 months, 83%. So I think it's amazing result. It confirms that transplantation is very active, not only for the short period of time, but for the period more than 5 years. And we can see these results. This is good statistic analyzing big group of patients. Interesting picture. This curve shows progression-free survival of secondary progressive multiple sclerosis patients after transplantation. Also big group, 160 patients with quite long follow-up. We can see follow-up time, 84 months. Many years it was considered that progressive multiple sclerosis is quite resistant for transplantation. Primary, secondary progressive, and it was also considered that secondary progressive multiple sclerosis as a primary progressive multiple sclerosis are not good candidates for this treatment. On this picture, we can see that progressive-free survival for 2 years was almost 90%. For 3 years, 87%. For 84 months, 76%. Now we're analyzing a little bit smaller group of patients with primary progressive multiple sclerosis resistant to all modern treatment, and our previous result for 2-3 years is around 75-77%. So it's good result. Much better than if we use any other disease-modifying modalities. On this picture, you can see quality of life profiles, relapsing remitting group and secondary progressive group. We can see blue diagram, this is before transplantation, and red one 1 year after. This is quite popular SF36 questionnaire, which allows to assess all modalities of quality of life of different patients. We can see this is physical functioning, role physical functioning, bodily pain, general health, vitality, social functioning, role emotional functioning, and mental health. We can see that before transplantation, all domains of quality of life were much worse than 1 year after. All domains of quality of life statistically improved. The same we can see in secondary progressive multiple sclerosis, but of course, if we compare diagrams, we can see the differences. The second diagram of secondary progressive group is more deformed. It means that quality of life of patients with secondary progressive multiple sclerosis is much worse than patients with relapsing remitting multiple sclerosis. Of course, this is because of high disability level. But also in this group, we can see improvement almost in all domains of quality of life. Long-term side effects after transplantation. We started our activity in 2005, and tragically we had some cases of mortality, and our transplantation-related mortality is 0.1%. This is much less than in many other centers. 3 years ago, we started new protocol, and no one passed away having this treatment. All long-term side effects were predictable and controlled. In COVID time, no severe COVID-19 infection were we didn't have any serious COVID-19 infection after transplantation. All cases of COVID infections were easy, mild to moderate. No one patient had to be treated in intensive care unit department, and as everybody knows, two long-lasting symptoms, fatigue and alopecia. And somewhat about our new protocol. Lots of questions about this protocol. As I told you previously, we published this protocol in a European Hematological Association conference. So this is open information, and you can see all doses of medication we use during this treatment program. This protocol takes 6 days, and we use cyclophosphamide in quite good dose, 100 milligram per kilogram body weight, during 2 days. And we combine cyclophosphamide with fludarabine in maximal dose, 150 milligrams per meter body square. This is maximal possible dose of fludarabine. It's important to tell you that fludarabine is one of the most lymphoablative medication. And this combination has synergetic effect. So one medication increases effectiveness of another medication. Also, we use rituximab for additional immunosuppression and additional B-cell depletion. Our previous result of this program published in European conference. Previous effectiveness is the same as traditional program. 4 days program, cyclophosphamide 200. But toxicity is much less. Firstly, no one cardiotoxic side effects, less cardiotoxic. Also, almost 5 times less rate of infections and fever. Almost 0% of hepatic toxicity. Almost 0 mucositis, oral enteropathy or diarrhea. Less needs of transfusion, only single patients who needed transfusion during this protocol. As you know, when we provide transfusion, this is additional sensibilization, additional risks also, but sometimes we had to do it. During this program, transfusion almost 0%. And also transplantation-related mortality 0%. No one patient had to be treated in intensive care unit department. Another previous result is quite interesting, immunological. We noticed quite deeper lymphoablation. Maybe we will have possible better long-term results of this protocol. And this is the last slide of my presentation. Dear friends, thank you very much for your attention, and I would like to show you some beautiful phrases to go ahead to fight the disease. So first one, only I can change my life. No one can do it for me. It's very amazing. In order to succeed, we must first believe that we can do it. And knowing isn't enough. We must apply. Wishing isn't enough. We must do it. So, dear friends, thank you very much. And now we are ready to our next stage, answering of your questions, discussion. So feel free to ask all questions you want to ask. Thank you very much.
Thank you, doctor. It was always interesting to hear you.
Thank you, Anastasia.
While we are still waiting, people prepare maybe questions. I would like to talk with you, and anyway, I know about lots of again questions, thoughts at the internet. People discuss, people ask, and of course, still one of the most important question for lots of our patients. It's a COVID situation. Can you again maybe give us any reply what about vaccination, about effect COVID if you get it after treatment, because it's very, very important for all of us, because I think very often problem when people really get it after treatment and really worry about result of treatment after COVID. Can it be effect or not?
Yes, thank you, Anastasia. It's a really important questions. It's really important talk. When we faced COVID-19 2 years ago, it was different infection. It was Delta variants of COVID, quite aggressive, with lots of lung damage and lots of dangerous things. Now COVID is getting much easier, and Omicron and other stamps of COVID, now this is a kind of normal, like normal flu, like mild influenza. So, as I told you during my presentation, we have never had any serious COVID cases after immunosuppression. Actually, we don't know about it, but we try to follow up all our friends after treatment. What's about vaccination? This is quite difficult question because on the one hand, we need to be vaccinated to protect us against COVID, to make COVID infection easier, to prevent severe cases of COVID. And of course, we recommend, according to international standards, COVID vaccination, especially before treatment. To provide enough amount of antibodies, we recommend to do it about 3-6 months before chemotherapy. What about vaccination after transplantation? For cancer patients, for non-autoimmune disease patients, we recommend to do it. For autoimmune disease patients, it's quite questionable because additional vaccination can increase the risk of relapse. So we need to assess risk and benefits of each vaccination. If COVID infection is easy now, and maybe not necessary to do it. Actually, I don't recommend to provide COVID vaccination now after transplantation, but before, yes. So the less vaccine we use after transplantation, the less risk of relapse. Another important thing, chemotherapy removes wrong cells, but chemotherapy almost doesn't affect antibodies previously produced by immune system. So if patient had good immunity before transplantation, patient will have good immunity after transplantation. So I think the conclusion is better to do it before transplantation, from 3 to 6 months time, and to avoid after. Of course, we support vaccination for very important reasons, like against rabies, new dangerous infection which can come, nobody knows about it. But for COVID, no. Maybe it was a little bit long answer, but we have lots of questions about vaccination after transplantation. So my opinion and my experience shows the less the better. For COVID, better to avoid. Another situation, social reason. For example, it's about people who work in hospitals, in kindergarten, in schools, and they had to be vaccinated. If they don't have vaccinations, they can lose their job. So this is social reason for vaccination. It doesn't mean that if patient has vaccine, he will relapse. So we need, in each case, we need to assess risks and benefits. For medical reasons, the less the better.
Okay, thank you a lot for so detailed reply. And the next we have question from our friend. I hope he can take part and we can hear and see him online. It's Rene. And we are waiting, yeah.
Oh, hello. Hello, hello, Rene. Nice to see you.
Nice to see you. Thank you. I have one question. I'm from Germany. I'm 30 years old. And I could have PPMS. So the doctor told me it's not pretty sure, but they think so. I have only one lesion on my brain. Only one, but I can walk normal at the moment, but my left foot and my left hand is going worse. Do you think with PPMS, with only one lesson, it can work for me?
To be honest, primary progressive multiple sclerosis is quite resistant and quite aggressive MS. Sometimes it's quite slow, but you are a young gentleman and we need to think about our future. You have one lesion in brain, but we need to analyze your spine because for PPMS it's quite
nothing. There's
nothing. So you
Nothing.
have MRI, cervix and thorax, spine, no lesions at all.
No, at my spine, nothing. Everything is clean.
To be honest, this is quite unique situation. Another important question is your progression rate. How you progressing during 6 or 12 months. If you are getting worse, transplantation will help you 100%. If you are stable, if your MRI is stable without spinal damage, we can wait.
It's stable. My left foot going a little bit worse. The last 12 months, my left foot has gone worse. Yeah.
Sometimes
my left foot, but I can normal walk at the moment.
look,
But
if
for the future,
if a MS patient is in wheelchair, it's too late to do this treatment.
Yeah.
If you feel that you have worsening, but your MRI is stable, it's quite difficult situation because MRI is limited to detect damage or inflammation, especially on cellular level. And you may have inflammation on damage which isn't detectable on ordinary MRI. Because now we have stronger machine. Now if we have new technologies to analyze MRI activity, MS activity like MR spectroscopy. This is new approach, but it's used in clinical trial mainly. And this result shows that some people with stable MRI are really active. So this is why we need to combine two options. Your MRI, which is stable, it's good, and your clinical course. If your clinical course isn't stable, we recommend this treatment. The time is from 6 to 12 months. Another thing, I think it's better to sleep well, knowing that you don't have wrong autoimmune cells in your body.
Yeah, okay.
But of course, your PPMS isn't traditional. We can wait. You have lots of time to make decision.
Okay. Thank you very much.
Thank you.
But you think it would work for me?
Sorry?
But you think it could work for me?
Yes, it could work. It could stop and prevent your further activity. Because if I understand right, you, for the last 6-12 months, you have new symptoms.
Yeah.
And of course, we need to... How old are you?
30 years.
So imagine your situation in 10-20 years. You need to have good life.
Yeah.
Primary progressive, usually cause of primary progressive MS from the beginning to wheelchair, in aggressive situation 2-3 years, in normal situation 5-7 years, in very favorable situation 15 years.
Okay.
This is from the disease onset to high disability level. So this is questions we need to think about.
Yeah. Okay. Thank you very much for your answer.
You're welcome. Thank you.
Thank you. Bye.
Bye.
Okay, very well. Thank you for your question and for your great reply, doctor. Very clear and understandable. And
Thank
we
you,
have
Anastasia. One remark. I think I try to explain all this situation because this quite typical questions for many people. And primary progressive MS is very difficult option. So this is why I try to explain so carefully.
That's true. And thank you for doing that. And we would like to invite another our patient who only is planning to come for treatment and have questions as well. So please ask Farik.
Hello, doctor.
Hello.
Nice to meet you.
Nice to
hello,
meet
you.
you.
Okay? Nice to meet you. Doctor, I'm 35 years old and I've had relapse-remitting MS for 6 years. And I feel like sometimes, my symptoms are getting worse. Like I have problems with my right leg, incontinence, my eyes, obviously my arms, the pain, everything. And I just wanted to know, like, if I take this treatment, what is the recovery rate? Is it 85 to 90%? And will I be, like, once I've had the treatment, would I be able to go straight into work, or will I have to isolate at home? Will people be able to come with me, like somebody in the treatment, or will I be in isolation in the hospital? I don't take no medication. So will that help me through the treatment, or is that a bit detrimental? Just questions like that, basically.
I understand. So situation you describe is quite typical. You have traditional relapsing remitting multiple sclerosis, as I told before during my presentation. Your success rate is around 95%. But symptoms of progression you describe maybe a first sign that your relapsing remitting MS is going to be secondary progressive. We need to do transplantation before this stage of transformation. What we can reach? We can stop MS with success rate of 95%. We can improve you to condition you had approximately 1 year ago. It's also possible. You will be in isolation hospital because we decrease immune system in COVID and influenza time. We need to be protected to provide the best care. So we prefer to provide 1 month of isolation for patients. But after treatment, there are no strict restrictions. You can contact your family members. You can follow healthy lifestyle, no special isolation condition, so no strict restrictions. Only 1 month of treatment in hospital.
Okay, that's perfect. Basically that's all I wanted to know. And once the application form and the money, everything's been set up, how long will it take for me to come to Russia and have the treatment? Will it be a couple of months until I get booked in, or will it be like once the application form done, a month later I can come and have the treatment? Like, how does that work?
For medical reasons, the earlier we provide treatment, especially in case of new symptoms, the better. What about organization? You have, everybody has our website address, our Anastasia's. She is administrator and she is responsible for schedule. So we can discuss your application anytime. We have waiting list, of course. And but it's flexible. I think Anastasia will answer, maybe, am I correct? Our waiting time now around 2, 3, 4 months. But it's better to address to Anastasia.
Right. Okay then. Yeah. Thank you, doctor.
You're
Thank you.
welcome.
Hopefully, I
Thank
see
you.
you in Russia soon. Hopefully. Thank you. Thank you. See you later.
Let's see you soon.
Yeah. Yeah. Thank you.
You're welcome.
Thank you, doctor, for your reply as well. So maybe I want to add anyway, people see us and we all know about our waiting list. We have places for now since April next year. So if you plan to come since April or later, it's totally possible. Maybe also should to add that visa is not a problem for nowadays, despite on all situations in the world. We easy help with invitations to our patients. We give you all instructions. You can apply for a visa, ask questions how to do it if you have any problems, for example, and you can fly to Russia also without problem. Just of course, as you know, maybe we don't have lots of direct flights for now. Lots of patients come to us through other countries like Turkey, Dubai, but it's possible.
Yes, yes. Thank you,
So it's one
Anastasia.
of the most important thing.
Our hospital provides great activity now because we need to help as many people as we can. Only one small complication, this is much less direct flights. Visa isn't a problem, medication, treatment isn't a problem. So we are open to help all people. Okay.
Again for information. It's very nice. So we have another patient with another interesting question, I hope, and let's listen her.
Let's do it.
Hello, I will speak for my friend.
Good evening.
She's very emotional, but she's the patient, and I will try
Hello.
to describe her situation. She's 33 years old. She was officially diagnosed in 2016, but her first symptoms occurred in 2010. She went blind all of a sudden 2 times. And she followed until now, she followed Coimbra protocol, and she was stable. However, this summer, she got worsened. She discovered 2 new lesions. And she heard about you and would like to pay a visit to you, but her doctor said that she's not ready yet due to emotional and psychological difficulties she's facing. And instead, she recommends her to follow Interferon or Aubagio. And she would like to know, what do you think about this recommendation?
Okay. Of course, I am not neurologist, I am hematologist, but you have quite a typical situation. Relapse and remitting MS, Coimbra protocol. Now it's proves that Coimbra protocol is temporarily effective. And lots of centers stop to use it. Another thing, risk of kidney damage using this protocol. So Coimbra protocol can't remove T and B cells. Every patient with multiple sclerosis has autoaggressive wrong immune cells, T and B. Interferon is quite old medication. If you try to provide search in the internet, it was big American research which proves that no changes between placebo, people who didn't have any treatment, and interferon in relapsing remitting patients. Only quality of life was much worse in group of interferon. So interferon only provide worse quality of life, but no treatment effectiveness at all. Aubagio, it's quite immunosuppressive medication, but also partly effective. We have lots of people who had Aubagio before transplantation. If you want to provide a choice between disease-modifying drugs and transplantation, I recommend to think about anti-B cell therapy like rituximab, acrelizumab, which are quite safe. But to be honest, transplantation is the most powerful approach. So our recommendation is transplantation. If you are not ready, no interferon at all, no Aubagio at all. Aubagio is very toxic and affects bone marrow, liver, lots of organ toxicity. Acrelizumab, another option. Or transplantation. If you are ready, we are ready to help.
Yeah. Well, the doctor, her doctor also says that this is what you've just said is the best solution. However, she is not psychologically prepared, and she would love to know what is the time that she can wait, for how long she can get ready. So she will not waste time. She's now in psychotherapy and doing kinetotherapy.
It depends on MS progression. If MS progression is quite slow or patient has less than 2 relapses a year, patient has time. 1-2 years, no problems. You can try, but try with Tecfidera maybe instead of Aubagio, but better with acrelizumab. And then as another option, or if you are ready psychologically, welcome to our hospital.
Okay, she has now 2 lesions, and she says that she has 2 active lesions, and she had 2 episodes of sleep paralysis recently.
It's important symptom. Look, another important consideration is spinal damage. If patient has lots of lesions in spine, risk of quick progression is very high. So if in spine.
Yes, was active, but now is not. Isn't.
It is only in brain.
You need to provide MRI, cervix, neck, and thorax.
I have.
In July is her last MRI, and she has all entire bone spine.
And now,
do you have lesions in spine? 2 active lesions in spine?
No,
in brain.
In brain.
But do you have non-active lesions in spine?
Yes.
If you have
I
damage,
have 1 lesion in spine, but it's not active. No.
It doesn't matter. For spine, it doesn't matter. So you had relapse in brain, you had activity, so you need to have quite intensive treatment because there are no any relationship between brain damage. Patient may have 100 lesions and run, but 1 lesion in spine can send to wheelchair. So this is why we recommend for almost all people with spinal damage to have intensive treatment. And the best option is transplantation. If you provide research in the internet, it's available. When clinical trial, American and European together, compared the best disease-modified drugs like acrelizumab, Alemtuzumab, Tezabri, and compared with transplantation. 55 patients from one side, 55 patients from another side. During the period of 5 years, in transplantation group, relapse only 3 patients. In the best disease-modifying drug group, 33 patient relapse. So 33 from 55 and 3 from 55. And this is about the best disease-modifying drugs like acrelizumab. It's not from me. It's published in open research literature. You can find it. This is a randomized clinical trial.
And the last very question, and we promise we're done. The protocol this with Coimbra, if it made her stable, until she follows all the psychotherapy and the stuff that was recommended, shall she follow the Coimbra until she decides to get to you?
It depends on your kidney functioning, because if during Coimbra protocol you had 2 active lesions, no. Go to acrelizumab or to transplantation, or firstly to acrelizumab and then to transplantation. This is quite logic scheme. If you are not ready, acrelizumab ready, or no effect of acrelizumab transplantation. If you are ready, transplantation now.
Thank you very much.
But you have time. You shouldn't do it tomorrow. Relax.
Thank you very much. Thank you.
You're welcome.
She needs that. Thank you.
Cool. Thank you, ladies, for your questions, and thank you again,
Important
doctor.
questions. Very important
That's
questions.
true, and very sensitive, I can say, right? And we have another lady, another girl, Maria, wants to ask also her questions. We are ready.
Let's do it.
So I just had a question. I have multiple brain lesions. I only have one spinal lesion, but my symptoms are very limited. Basically, it's only the hermit sign. I was just wondering, would it still be a good thing for me to go through the HSCT protocol, even if my symptoms are really like?
Could you tell me how many relapses a year you have?
I was diagnosed just in August now. So I only had,
in
like,
August.
so
And
this is my,
do you have
yeah.
many lesions in your brain?
Yeah, more than 40 lesions, they said in my brain from my MRI.
So this is quite big amount for the beginning. Your disease causes, I think, not 1 year. I think it's around 3, maybe 4, 5 years. But spinal lesion is a negative prognostic, unfavorable prognostic factor. So difficult to tell you, go right now. You need to make this decision. But based on clinical situation, if patient has more than 40 lesions in the beginning with some spinal damage, transplantation is highly recommended. And look, your situation is very good. You don't have many symptoms because MS is chronic disease. MS affects quality of life. Each day, each month, wrong cells destroy nerve cells. This is like a fire in our house. The earlier we stop fire, the more we save. So the earlier you stop aggressive process inside of your body, the more nerve cell you save.
So we still be good. Okay, get it. Thank you very much. I just have a quick question. There's not for me, but if you have any type of like a fungal infection, like on your nails or anything, you cannot go to the protocol, right? You have to get rid of the fungal infection. Like if you have nail like fungus infection, you have to get rid of any infection before you cannot do the protocol. Is that correct?
You mean infection during treatment?
No. I mean before you even enter for the protocol, not during the.
You mean infection before transplantation? Infection.
Yes, before, like just like on the toenails, for instance.
You should treat infection as usually. Absolutely. Sometimes infection can be a trigger of relapses, but of course, if you go for transplantation, you should treat infection because we are going to decrease immune system. You should be infection free. If you have some chronic infection, it's better to cure it.
Okay, so you have to cure it before you.
But general logic is, if you have infection like COVID, influenza, you shouldn't delay with treatment. You should treat it as soon as possible, and you can use all modern medication for you. No restrictions, if you mean this situation.
I was talking more about the chronic, like on the toenails, the fungus that, they need like.
You mean chronic infection? What kind
Yeah,
of
fungal infection.
fungal infection? So during our protocol, firstly, each patient has very careful examination. We provide all tests for infection, viruses, bacterial, fungals. Also, transplantation protocol includes antifungal prophylaxis. So you can't be worse with fungal infection. If patient has fungal infection before treatment, firstly we treat infection and then we go with immunosuppression. And later we give prophylaxis. So no worries about it. Yeah, well, thank you for your question.
Okay, doctor, you do great job, like always.
Thank you, Anastasia. You do great job too.
Thank you, thank
And you look nice.
We are good team. I prepare for New Year holidays, and I hope I can imagine some atmosphere like that. So we have another nice man who wants to ask also few questions to you. Let's listen to him.
Let's listen.
Hi, doctor. How are you doing?
Hello. How
Thank
are
you
you?
for doing this. Good. Okay, I have. I'm diagnosed with relapse-remitting MS like 1 year ago with EDSS level 3, and now I started on Kizimta, the Ophthalmomab, or it's a disease-modifying therapy. The Kizimta,
Anti-B cell therapy, I know.
Yes, Ophthalmomab, and that's like the once a month treatment. Okay, and I've been now 7 months on it. Okay, and the last visit with a neurologist, he told me I'm getting better, which I feel some symptoms went away already, but some symptoms I still have it, like sometimes weakness in the right leg. It's getting worse during the day, and at night it's getting better. So he told me I went from EDSS level 3 to EDSS level 2. I don't want to make the direct to the question, so I don't take too much time. So I'm really considering the stem cell transplantation because I have lesions in thoracic and cervical and the brain. And I have 2 lesions in the cervical and the thoracic. Okay. So I think, and also my age is 38. So I think I have a very like a prognosis, like it's gonna be. It's not a progression in the future. So my question is, like you talked at the beginning regarding the relapse-free period with the stem cell transplantation, but how about the progression? The progression with the relapse remission. With the
I understand your question.
Getting...
Firstly, look, you are in good situation now. You have relapse and remitting MS. So your follow-up result, this is relapse-free time. If relapse and remitting MS goes to secondary progression, assessment is progression-free time. So success rate for you, because you have relapse and remitting MS, early MS, is around 95% based on our and international statistic. But you have negative factors, spinal damage, cervix, neck, and thorax. This is unfavorable situation which give us information. Maybe you won't have it. I don't know. But the risk to have in secondary progressive phase earlier than people without these lesions is much higher in your situation. If you do transplantation now, you won't progress at all. So you will be relapse-free because we stopped MS and relapse and remitting phase. And we prevent transformation relapse and remitting to secondary progressive phase. And of course, you will be progressive free with the same rate. So what's about your situation? Better not to waste time.
Okay. Thank you for this. And I also have another question regarding the long-term side effects. I know the short-term, like infection, but what about the long-term side effects and how we can avoid them?
Modern protocol is absolutely safe. Fertility, effect on fertility is almost 0%. Two long-term side effects. Alopecia, when patient loses hair, it's temporary, and lack of energy and fatigue during 3 months. Healthy life, physical activity, healthy food, positive mind. This is the most important thing to deal with this problem. But there are no risks for if you use new protocol. If you mean this situation, there are no risk of secondary malignancies or secondary autoimmune disorders. So no risks for this protocol. For old protocol, for myeloablative protocol, risk was high. Now it's 0.
Thank you.
You're welcome.
Okay. One more last question, doctor, regarding the conditioning regimen. You told us regarding the cyclophosphamide with rituximab and another medication.
Fludarabine.
Is there? Yes. Is it like a standard way of doing it at the center, at your center, or because I am like trying to see what's the best conditioning regimen, comparing the two like different stem cells together. This is in terms of result. Is it?
This is standard treatment. It's safe and quite effective. Also, this is not from us. This protocol combinations of cyclophosphamide with fludarabine started in the USA firstly. Richard Bird started to use this program. Also, Singapore started to use this program, maybe in a little bit different combination doses. But this program isn't from our center only. This is a kind of international standard.
Okay. Okay, one last question. You answered before, but I just want to clarify it. You told us that the vaccination is important, but it has to be considered case by case. Okay, so my question is it a good thing to do, because I'm considering the stem cell transplantation, is it a good thing to check the antibody levels of the most important disease that our childhood vaccination I got before? Should I update them before going to the transplantation?
This is quite wise option. Before making decision to have vaccine, it's quite important to check antibody level. So you should do it. If you need to repeat vaccination, repeat it before transplantation and welcome.
Thank you so much. Thank you
You're
so
welcome.
much. Thank you.
So, thanks again for your question, Sam, and thank you,
And
doctor.
thank you for your
again.
assistance.
Okay, so important really to talk about vaccination, and I understand that maybe I'm not so well patient. I don't do any vaccination.
Today is a quite important webinar because we have a live discussion and with lots of very, very important questions.
That's true.
Previously, we had mainly diagrams, slides, and much less understanding of this process and much less so wise and important questions. Now time is changing.
No, that's really good when we hear each other with our patients and can help them to understand much more or maybe reply on exact questions. And we have another lady. She wants to ask a question as well. So we are ready to listen, to hear, and to see. Julie,
We are
Marie,
ready.
please.
Hi guys.
Hello.
I
Nice
was
to
just
see you.
Nice to see you too. I was just diagnosed with MS in July. I was diagnosed with relapsing remitting, but none of my lesions are active. So I'm a little confused on the diagnosis. I have 5 lesions in the brain and I got NETA, no evidence of disease activity, and 2 lesions in my cervical spinal cord. And the enhancing dye did not pick up on it. And so I'm just wondering if HSCT is safe for people with non-active lesions, and does that mean I'm closer to secondary progressive because they're not active? I'm just a bit confused on my diagnosis as a whole.
It's an important question because some people never have active lesions. For example, people with primary progressive, this is not your case, the vast majority of these people never have active lesions. If patient doesn't have active lesion, it doesn't mean that patient is without inflammation. Inflammation can be detectable on MRI. Some people has relapses, clinical relapses, no activity on MRI. Doctors use steroids, remove clinical activity. So MRI can be active clinically, radiologically, or both. The most important that you have spinal lesions. Doesn't matter, active, non-active. This factor give us very important information that risk of secondary progression is higher than for people who have lesions only in brain. As for you, transplantation can be useful.
Okay. And I guess I'm an EDSS1 right now. I only really deal with sensory issues for now. My quality of life hasn't been affected yet. Do we know why some people is it because of protocols, some people get worse after transplants? Is there any studies on why some people progress afterwards?
Look, firstly, when we provide our first statistic analyzed, we compared 2 groups of people who had active lesions before and who didn't have active lesions. Long-term relapse-free or progression-free survival was the same. So gadolinium activity, MRI activity isn't so important for transplantation. The more powerful MRI machines, the more active patients we have. Also, if you use another machine like MR spectroscopy to assess activity, we have another approach to this activity. And why we need to wait for a DSS 8? Because it's too late. Temporary worsening in condition is quite typical for very disabled people and for heavily pretreated people. So the less pretreated person, the less disabled person, the better result. Of course, transplantation can't guarantee 100% of result. But if we compare 95% for transplantation with around 15-20% using our anti-B cell therapy all time, this is quite big difference. Clinical trial, American, European, the best disease-modified treatment, 33 patients relapsed from 55 in DMD group and 3 relapsed from 55 in transplantation group. It's published, you can find it in the internet. Richard Bird in the USA and company from Europe. So this is why we recommend. But our experience shows that spinal damage, active or non-active, this is additional factor to have intensive treatment. So, but of course, if your MS is very early and your DSS is still 1, you have time to make decision. This is not urgent situation.
Okay.
But you should think about it.
Okay. That's why I'm a figure skater. I'm very active. I don't want to lose those abilities. So I'd rather nip it in the butt before, any permanent damage.
In early stage, if you provide transplantation in early stage of MS, only maybe lack of energy or fatigue during first 2-3 months is possible, but not in all people. That's all.
Okay.
Temporary deterioration is quite typical for people with higher DSS 6 and more. So you will be the same active after transplantation, maybe a little bit more tired in the first 2-3 months. That's all.
Okay. Okay.
But your positive mind and your physical activity can deal with it.
Right. I feel like I can tackle this for sure. Can Lemtrada affect my bone marrow? The neurologist here, I'm on Ocrevus right now. They want to jump me on Lemtrada next year, but for me, it's either Lemtrada or HSCT. Could Lemtrada mess up my bone marrow and ruin my chance?
Yes, it can, but Lemtrada is quite strong. Strong not for MS, but strong for body. Lots of virus complications, much more virus complications after Lemtrada than after transplantation. And look, it's quite logic. In MS situation, we have autoreactive T and B cells. Acrelizumab removes B cells. Lemtrada removes T cells. No one removes both, only transplantation. High-dose chemotherapy allows to remove T and B cells. You can't have Lemtrada and Ocrevus at the same time.
No.
So this is why transplantation is much better option.
Okay.
Make a decision. We are ready to help, but you have time. No stress.
Okay.
Thank you for your questions and have a nice day.
Thanks.
Maybe you have a... Okay.
Hope we were very successful for her. I hope she will do the decision and it will be right for especially for
yes.
this. And we have another guy, Mohammed, wants to ask his question, my dear doctor. So let's listen to him too.
I am ready.
Me too. So maybe some problem with our techniques, but should be fine. Honestly, I have just talked with him. So he's a real person.
Hi, Mohammed. Nice to see you.
Hi. How are you, doctor?
Fine, thank you. How are you?
I'm fine. You hear me well?
What question do you have?
Look, my son is 11 years old and he's diagnosed with MS, okay, about 1 year ago, 1.5 years ago. And doctor recommended Gilenya as it's the only medicine DMT approved for 10 years old. But after researching, I found that many people who take Gilenya already has MS flares afterwards. So I didn't give him. And we stuck to diet change and Coimbra protocol. And so far, so good. You know, there is slight improvement in the lesions, okay? And he's doing well. He's active. He's athletic. He plays basketball. And we have no problems. We make the MRIs every 4 to 5 months. And, you know, the last MRI shows slight improvement. My question is it worth to make the AHSCT for him at his young age? Is it worth risking the side effects like the infertility and the other the bone problems that could happen to the, you know, as a result from the chemotherapy? This is question number one. Question number two, if it's possible, if we're going to make it, how is the situation in Russia? I mean, I know there's a war going on and stuff. So is it the place where you guys you make the operation, is it safe? There is no problem for the flights and so on? That's my question.
Okay, look, let's start with medical questions. Firstly, I am hematologist, and we are an adult hospital. We can treat people with, I think, with 14 years old. Anastasia maybe will give additional information, but I think with 14 years old. Child MS is a little bit different than adult, and pediatricians have special child protocol, and I recommend to follow child neurologist recommendations only. In Russia, we don't use Coimbra protocol. We consider this protocol isn't effective and quite toxic. And it can be toxic for kidneys also. It's difficult questions to me, to be honest, because I am not a pediatrician. We can help your son in 2-3 years, I think, in 3 years. But before this time, you need to follow recommendation of your child neurologist, of your pediatrician neurologist. So in Russia, we use Gilenya for children, and it's with quite effective result. Gilenya is quite safe medication. But these questions, your question is mainly for neurologists. What about transplantation in so young age? We don't provide it. And we consider it can be more dangerous than for adults. The youngest people we provided was 14 or I think 15 years old. MS is quite slow disease, and I think you have time. We have experience in Moscow in pediatrician hospital who transplanted children with a very aggressive opticomyelitis disease. So this is only one indication for transplantation for children, opticomyelitis, because it's very aggressive disease and very resistant to all treatment. In your situation, you should follow your neurologist recommendations. Sorry, maybe not complete answer, but I am not a, I am adult doctor.
But okay, no problem, doctor. Thank you. You're trying to help. I appreciate it. But my question is about the 14 years old. I mean, after 3 or 4 years, if we decide to do it, still going to be the risk of infertility and the other side effects. So my question is it worth it at that time? Because infertility for a little teenager like 13 or 14 is not the same as for someone who's 40 or 45 years old.
I understand your question. There are no any research, but modern protocol is quite safe. Modern protocol almost doesn't affect on fertility in all people and ladies, and we have young girl who transplanted in 15, 16 years old, and they have successful pregnancy and delivery. So, but there are no big research. No one provided this research.
We should wait. Yeah, we should wait and see. Okay. About
we
the
need
safety.
Time. We need time.
The status in Russia, the war status. How is it going? Is it safe? Because my friend also was talking to me about he's thinking to come to you in Russia, and I was concerned about the situation. I don't live there, so you guys live there, so you can give me a better picture, about the flights, and is it stable? We can come. Is it safe?
I don't know about situation in 3-4 years. Nobody knows. But now we are active. We have lots of people who came to hospital, maybe a little bit complicated flight, but no visa problems, no other organizing problems, so everything is okay.
Good. I hope this situation ends soon, and you guys we will be safe, and I hope you safe too.
I think situation will be much better in 1-2 years. I hope yes.
Yeah, I hope so. I hope
But
so.
of course, we can't predict our future. I hope everything will be
But
much better.
now there's no problem because my friend was asking, he wanted to come, about this period, like in the next. My friend also has MS, so he was thinking to come in the next, like 4 to 5 months.
It's
So I
not a
was asking
problem.
him,
It's not a problem. Now we have waiting list. We have people for January, February, March, and we are now we are forming a waiting list for April and May. So welcome. No problems now.
good. Okay. Thank you.
You're
Thank you,
welcome.
doctor. Thank you.
So you're welcome. Bye.
Bye.
Okay, happy to see you again, doctor. Thank you for lots of details, and for children also so difficult always to
questions,
reply.
not
Yes.
standard situation.
We'll see. We'll see. So anyway, we have to continue, and we have another our lady with a question. Our former patient, Maria. We are very happy to see you.
Very happy
Hello,
to see
Maria.
you too.
Happy to
Hello.
see you.
Hello.
Hi.
Very, very happy to see you too. I'm doing absolutely fine. You gave me my life back, honestly. It's just amazing. I can't describe it. I can't thank you enough. I have a question which I'm not sure if I could ask, but I'll risk it. Many people are asking me these questions because they're looking for treatment and they're considering Russia and Mexico. So can you please tell me the difference between the two protocols in the countries, because I don't know what exact answer to give them.
Okay, it's a partially difficult questions for me. We are big governmental research center. We are not private hospital. As I know, Mexico is private hospital.
It is
Of
private,
course,
yes.
of course, they provide chemotherapy. They provide chemotherapy, and it's good for multiple sclerosis patients, but we have a little bit another approach. We consider that we need to give completely lymphoablative chemotherapy. It means that we need to give very strong treatment which allows to remove all autoimmune cells. This treatment is possible only in sterile condition, which we provide. So we didn't compare statistic Moscow and Mexico. I think they provide good treatment, but our opinion is that we need to not to delay two chemotherapy doses for 10-14 days, because chemotherapy isn't a summary dose. Chemotherapy isn't only a summary dose. Chemotherapy transplantation is a summary dose for very short period of time without any break intervals. If we do it, we provide
the way they do it in Mexico.
High concentration. If you have high concentration of chemotherapy, we can remove more autoimmune cells. We provide deeper immunosuppression. Of course, our colleagues in Mexico provide good treatment, and I know about lots of successful transplantation in Mexico, and I am really happy that they do it, because more than 2 million people around the world, 2 million MS sufferers around the world. So we are on the one way, but scientifically, our position is to give very strong treatment for short period of time. And so this is why we need to have lots of other specialists, MRI machine, intensive care unit department, cardiologists, all specialists. And this is why I think university hospital is a good place to provide comprehensive treatment. So difficult questions to me, but they also give good treatment. But we have
Yeah,
another opinion.
I usually tell them that for me personally, Russia is way more safer because you're in the hospital the whole time. You're under the care of all the nurses and doctors all the time completely. Whether in Mexico, you are outpatient. You need to bring a carer with you. You're not in the hospital.
I understand you. It's better to ask patients because I know about lots of good stories from Mexico, lots of good stories from the USA, lots of good stories from Russia. As for our hospital, we provide the safest treatment because we use sterile condition. We are multi-dimensional hospital. We have, if we need to have cardiologists or surgeries or intensive care unit department, everything is here. Another thing is our new 6 days protocol. We found that on the one hand it's quite safe, but it should be done like in patient treatment. On the other hand, we can see very deep immunosuppression, zero lymphocytes at all. So,
Right.
so our position, not summary dose for transplantation, but not only summary dose and time of this dose. And the name of this approach is dose density. Transplantation is dose-densive treatment because it was a big research in the USA when they give cyclophosphamide every month during 1 year for other autoimmune disease, systemic sclerosis, and they gave the same dose for 4 days, and the result was very different. No effect at all for monthly cyclophosphamide, and the great result for 4 days cyclophosphamide. Summary dose was the same, but dose density was much higher in transplantation program. This is quite famous and well-known research for systemic sclerosis, very aggressive autoimmune disease.
Thank you very much.
For MS, I think the position is the same.
Right. Thank you so much.
But I wish all people who is going to visit Mexico to have good luck and success to stop MS. So I only support people who make decision about transplantation.
Yeah. For me personally, Russia is the best option, but yeah, this is me. You saved my life, so.
Of course, this is your opinion. Some people can tell about other hospitals. Of course, difficult to compare centers and approaches. The most important thing is to treat person with MS, but not only MS, to provide the best and the safe care and to give effective enough treatment.
Right. I just want to wish to every future patient the best of luck and to tell them that they would be in the best hands ever. The best care ever.
Thank you very much.
Thank you so
very much. And thank you for your positive mind, because you are successful not only because of our hospital and transplantation, but because of your power, your stride, and your motivation.
Thank you for your kind words. Thank you very much.
Thank you. Bye.
Thank you. Best to you. Bye.
After so cool feedback of our patient, I'm ready to work and work and work.
It's so nice to hear good words about
for sure
to see good results.
Exactly, and it's really inspired and it's very helpful and for us. Thank you again for sharing your story, your warm words and feedback.
And I know about her results of MRI. It's amazing.
Yeah, that's good. And what I have to say, I hope it's not a secret, she came back to Russia just for MRI. It's also possible.
Yes.
And we have...
It was a complete remission.
Yeah, that's good. Nice. So maybe let's continue with another question. We have
Yes.
also another patient, our former patient, who have just finished transplantation in our hospital and have question for you, doctor.
Yes.
Yavor Milanov.
Let's discuss.
Please welcome.
Hello. Hello, can you hear me, doctor?
Hello, Yavor.
Hi, I don't know why the camera is not working, but that's okay.
Okay, but I can hear you.
Oh, there you go.
Oh, hello, I
Okay.
can see you.
Nice to see you again, doctor.
Nice to see you.
Okay, so straight to the point. So as planned, the first 3 months right after the treatment, I was, generally very careful not to pick up any viruses and just to stay on the safe side. And I was feeling everything just, with small ups and downs. Generally, everything was getting better and better. Well, unfortunately, like a month ago, I picked up some virus somewhere, and then I was very slow to recover from the virus, like something that hasn't happened to me before. Meaning, like I had a cough for 3 weeks, mucus coming out, and that that kind of scared me a little bit. However, during that 3 weeks of the virus, I didn't feel any MS symptoms. But just as I started getting better and really stopping my cough and stopping to feel any effect from the virus, I started having the MS symptoms back. And now I contacted other people from the group that I'm part of online, and they said, "Oh, that is very normal. Like it's very normal that once you get sick to have longer recovery period, and also to your old MS symptoms to flare up again." However, like I just want to verify with your doctor if that is the case, and also how can people be sure that this is not the MS coming back, because this is the natural fear, of course.
Look, when we provide intensive treatment, we remove cells, but we don't treat damage. So recovery process takes time. For active MS, it's around 3-6 months. Another thing, chemotherapy is quite safe and well tolerated, but it isn't a switch. And we notice that quality of life is usually worse during 3, sometimes 6 months and improves to 12 months time. We have never had cases of relapse, of MS relapse earlier than 1 year after transplantation. It's nonsense. All these symptoms were explained by roller coaster, chemotherapy effect, or other things like infection, stress. The better rehabilitation patient has, the better recovery. So this is why we recommend good rehabilitation, vitamins and supplements, physical activity. How to differentiate between MS-related symptoms? You mean progression? Usually, if patient has MS symptoms after transplantation, this is after infection, after stress, after bad sleep, and after stress after some time, these symptoms getting better. If patient has MS progression, patient can't be better without specific treatment. But all symptoms are inside first year after transplantation are usually related to chemotherapy and all damage. So I don't think you should worry about MS progression in so early time. This is quite typical situation.
Thank you, doctor. I wasn't quite worried about progression. I was just worried that it was not successful as a therapy. and that's that was the case.
It's when we discuss, I told you, to be 100% successful, you need to be 100% confident in your success. Avoid stress, avoid doubts, be positive, and go ahead to your new healthy life. Think about only 100%. Know about risks and treatment failure. Enjoy your life.
All right, doctor. Thank you very much.
You're welcome.
Okay, doctor, thanks a lot again about that
Thank
important
you.
situation. To be honest, I have also something similar after my transplantation. I felt symptoms, and it's totally normal. Like doctor said, don't be worried. Needed time. Unfortunately, nothing happens for one day like that. It's normal.
Anastasia, if it's possible, some remarks. Dear friends who take part in our webinar, look, Anastasia, so many years after transplantation. You can see the result right here. Nothing to discuss.
Okay, the best and the quickest reply. I like it.
Nothing to discuss. Look at
That's true.
Anastasia.
That's true. Anyway, we have another question. Dear doctor, Maria has already spoken with you right now, but she has additional question if you
Okay.
don't mind. So Maria, please welcome and ask.
Yeah, thank you so much.
Mhm.
I
Okay.
just have, this is more like more of a technical question. I'm just trying to understand like the pathophysiology of the disease. My question is, right now, what is happening in MS, the B cells, T cells, like my immune system is basically attacking my own body, right? Like my nerve cells. But my confusion is that I make new B cells and T cells every day, right? From my bone marrow. And why is it that, and then the T cells and B cells already existing will eventually die off, like there is a specific lifetime. Why is it that, how come my T cells and B cells are always then,
Are you
why do I
researcher?
keep having the?
Are you researcher?
No, I'm a medical student. But
You're a medical student, yes?
yeah.
Okay.
Yeah.
It's quite important and good question. All we have genetic instability in our body. So in other words, all we have weak places in our body. And lots of triggers, stress, viruses, psychological situation, everything. Because all we have weak spots in different places, and all we are different. Some people stronger, some people less resistant or more resistant. After these triggers, some people have immunological mistake. Because all we are different, one person has cancer, another person has stroke, another autoimmune disease. So these weak spots start to be broken. In case of MS, this place is immune system, and T and B cells started to make a mistake and to think that some our cells are wrong after triggers.
Yeah.
And these cells are self-producing. This is group clones. This is clones. This is cells which came from one cell, one defected cell. We remove these cells and we transplant back not T and B cells, but stem cells which are healthy. In case of MS, stem cells are healthy. If stem cell is sick, this is condition like a plastic anemia, we need to provide allogenic transplantation. So we remove wrong T and B cells and send healthy stem cell back, which receive information that immune system removed and start to build new immune system. Of course, we can't edit our genes, and risk to have relapse after transplantation is higher than in general population. The same example, if we treat cancer in early stage and if we reach complete remission, risk to have relapse is higher than in general population. So this is the same. We only send biological clock back before this mistake, but weak spots is still here. This is wise question. But we don't transplant sick cells back. We take stem cells, provide deep freezing to save these cells from effect of chemotherapy, remove bad immune system, send stem cells back, and this stem cell produces new healthy immune system. And of course, condition started to be like before this mistake. But of course, risk is still here, and this is quite important questions because many doctors don't understand it. So thank you for this question. It's important.
Thank you very much. Thank you.
You're welcome.
Thank you so much.
Okay, doctor, thank you again. And for today, I think we have the last question to be ready soon home. So
really last questions.
Yes.
I'm ready to be here all night. Why not? If you can help, why not?
Okay, your choice. But anyway, Rene, our former patient again, he has a question for you. I hope you're ready. Let's see. Rene, we are listening to you.
Oh, hello, Rene.
Hi.
Nice to see you.
Yeah, a long time no see.
I know you are successful.
Yeah, well, I am. To be honest, the last MRI that I had in Amsterdam in September, beginning of September, was pretty okay. So my neurologist told me that at least the treatment was successful. So that's perfect.
I am happy. Good news.
But the thing is, it feels like I'm going, well, let's say backwards. So walking is becoming a bit more of a problem. And so I discussed it with her, and she said to me, well, the thing is with PPMS, that it could be when the MS is already really in the nerves, that could be a problem, and that could be the thing that at least the treatment won't work with that. Is that true?
Of course, it's quite difficult to understand about your progression because of primary progressive variant of MS. Important thing, for example, how we need to assess your situation. We need to compare your ADSS score now and ADSS score 6 months ago. If your ADSS assessed by a neurologist the same, you are not in progression. You may have more symptoms, but you are not in progression if your ADSS score is stable. We have criteria for progression. This is ADSS increasing 0.5 or 1 for 6 months. If you have it, unfortunately, we need to give you additional treatment. If not, but you feel worse, you are still in remission. Another reason, it's better to understand what is the reason of your bad condition. Maybe chronic infection, chronic stress, lots of reasons. Another thing, I recommend physical activity. How many days every week you visit sports twice I recommend 4.
Okay.
Try to do it. Also,
Yeah.
you can discuss with your neurologist some symptomatic treatment like Sativex for spasticity. If you have sleep problems, you need to normalize your sleep. You need to think about what's wrong. Because sometimes bad sleep, stressful situation, family condition, everything, chronic viruses. But the criteria of progression for primary progressive MS is increasing of ADSS.
Yeah.
If your neurologist doesn't confirm your increase of your ADSS, you are still in remission.
Okay. Okay. Well, perfect. Well, the only thing was because I had COVID in this year in March.
It explains.
Yeah.
Post-COVID syndrome, strong, healthy people suffer from post-COVID situation at least 6-12 months. And I know that lots of supportive medication like meldonium, vitamin supplements can help in this situation, and try to discuss it, try to be active to find the reason. COVID can affect nerves. This is why people lose some functioning during COVID infection.
Yeah.
Like nose problems, because this is neurotropic virus, and lots of people have worsening after COVID, especially after moderate to severe COVID. But on the other side, lots of supportive medication, lots of rehabilitation program, oxygenation and symptomatic treatment, more physical activity, yoga, fitness, swimming pool, decreasing of body weight.
Okay. Well, thank you.
I wish you success. Let's be in contact, Rene. Let's be in contact. We will try to find a solution. To be honest, I don't think you have progression of your PPMS, because the reason is you are PPMS free.
Yeah. Well, I think
Keep it in your mind.
Yeah. I will. Thank you very much.
You're welcome. Have a nice evening.
Same to you. Thank you.
Super, doctor. I think we are finishing for today. And in the end, I just want to wish everyone a really happy new year and Merry Christmas. And we are very happy to listen to each other, to see each other, and to do it, what we do together.
Thank you, Anastasia. Thank you for your support. And dear friends, I wish you to have great Merry Christmas, Happy New Year. And I wish you to find all your difficulties in this coming new year to make right decision. Have a nice day, good luck and success. And thank you very much for taking part in our discussion. It was amazing, I think.
Yeah, thank you.
Thank you, bye. Bye.